and they'll send it for a genetic material for the virus. So if the swab is positive, then we know for sure that you have COVID-19. However, if the swab is negative, there's very rare instances where it can be negative, a false negative. What that means is the swab is negative, but you do have COVID-19. Again, this is very rare, but the main instances where I've seen this happen is based on the quality of the specimen, where it usually, if it didn't go far back enough into the throat, or it didn't stay long enough. So in case that happens, what we usually do is try to collect another sample. We know for sure that the nasopharyngeal swab is better than the throat swab, but then the anything samples from the lungs is usually better. So that means if they're able to cough anything up, we'll send the sputum for the virus as well. What usually happens in the hospital setting is if we have a high clinical suspicion that this is COVID-19, but the first swab is negative, then we will consider testing the swab again or send a sputum sample. I just want to emphasize that everything I talked about so far is about testing in the hospital setting. So this is not does not relate to testing in the community setting. So in the hospital setting, it's where the doctors will assess the patient and make that decision. However, for the people at home, what I recommend to do if you are exposed to COVID or have any symptoms is you go on the online website, as I outlined here, which is an online COVID-19 self-assessment tool by the Ministry of Health, Ontario. And that tool will ask you what sort of symptoms you have, and then tell you what to do based on the symptoms that you have, whether it's to remain at home, to get testing, or seek medical attention. So now I want to move on to management of COVID-19. So the management that we do in the hospital is based on already published, established guidelines. We have a guidelines already published in Canada that was published on April the 2nd, as well as guidelines published from the US, which is published in April 11th. So I just had the reference down below. If you want to check it out, it's free to the public. So across all those guidelines, what I want to emphasize is that the recommendations have been very consistent. And what we focus on in the hospital setting for treatment is mainly supportive care. And what I, again, want to emphasize is there's no COVID-19 specific therapies that's recommended currently outside of clinical trials. So the best way to think about management is to consider the spectrum of disease for COVID-19. The most useful way, in my opinion, to categorize it is to split COVID-19 infection into 3 categories. So as you see here from left to right, you have the mild disease, the severe pneumonia, and also the critically ill. So the percentages I had here is based on a large study coming from Wuhan, China, that had more than 70,000 cases. And then the clinical presentations, it's based on the Canadian guidelines. And then the management for the corresponding severity is also based on the Canadian guidelines. So just going from left to right, we're going to start with mild disease. And this is going to be in the majority of patients. So going to be in 81% of the cases. What you're going to have is very mild symptoms, almost like a common cold or very mild pneumonia. So in those cases, the infection will resolve by itself and you do not need any treatment. What we do recommend for you is to isolate yourself at home and monitor to make sure the symptoms do not get any worse. Going now to severe pneumonia. So this occurs in about 14% of the cases. And the presentation for severe pneumonia is based on difficulty breathing. So that's what we call respiratory distress. That means if you're breathing really hard, that means more than or greater to 30 breaths per minute, or you have low oxygen level in your blood. So in those cases, what we do is we assess the patient and we admit them to the hospital for monitoring to make sure it does not get any worse. And for the low oxygen in the blood, if they do have it, we'll give them supplemental oxygen, usually through the nose, to make sure that their oxygen level in the blood remains normal. And as we know that if it's confirmed to be COVID pneumonia, we know this is a viral infection, therefore there's no role for any antibiotics. And lastly, the most severe cases will be called critically ill COVID-19 infections. So that's very rare. It occurs about in 5% of the cases. and almost all of the mortality, people who die from it, will be within this category. So of all the COVID-19 infections, our best estimate for mortality, people who die, is estimated to be around 2%. The clinical presentation for the people who are critically ill is usually to have respiratory failure. That means that your lungs cannot breathe for you, and that means you need a breathing tube to be on a breathing machine and life support. The main reason that we intubate people is due to a complication from the COVID infection called ARDS. ARDS stands for acute respiratory distress syndrome, which just means a severe inflammation immune response within the lungs that causes lots of fluid within the lungs, such that your lungs cannot breathe for you. If this immune response and inflammation goes outside of the lungs to the rest of the body, then there's a complication what we call septic shock. In those cases, what you have is very low blood pressure. And when you have very low blood pressure, you have low levels of blood and oxygen supplying to the rest of your organs. And that's when you go into multi-organ failure, which is a cause for death. One of the most common organs to be affected is your kidneys. So you go into kidney failure or renal failure. For those critically ill cases, what we do is we monitor and care for them in the intensive care unit in the hospital. And we try to optimize what we can by supportive care. By supportive care, I mean we try to optimize their mechanical ventilation. That means a breathing tube and a breathing machine. As well, if their blood pressure is very low, such as in septic shock, we give them lots of IV fluids and also special medications called vasopressors to increase their blood pressure to the normal range. And if they have organ failures, we try to temporize and try to replace those organ functions. For example, if you go into renal failure, what we do is we put you on temporary dialysis. So in those cases, when you have severe patients who's in the ICU, there are risks for other infections as well. So if it is suspected that they have a bacterial infection, such as a superimposed bacterial pneumonia, then we add antibiotics. And currently, based on the recommendations, there's no role for steroids. That's all I had in terms of the management and the supportive care. So now I'm going to move on to the specific COVID-19 therapies that's currently being studied. So there's a lot of options, and currently in the world, there's about 300 clinical trials going on right now. The two most famous one and well-known one is the one I'm going to talk about next. So the first one is called hydroxychloroquine or chloroquine, and the second one is called remdesivir. So before I go into detail about any of those two treatments, I just want to give the bottom line right now, and that is there's not enough evidence from clinical studies to support the use of any of those above therapies for COVID-19 in the clinical practice. So we do not use it outside of clinical studies and clinical trials. So this is just a diagram to show how the virus infects the cells in the body to cause the infection. So if you can follow my mouse here, so this is the virus. The virus is called SARS-CoV-2. It binds and enters a cell, such as cells in your lungs, to cause infection. Once it enters the cell, it's going to try to replicate its genetic material and other components too to make progenies. And these sort of daughter virus particles will then exit the cell to infect other cells, which causes and propagates the infection. Outlined here are different targets that's currently being studied, specifically to treat this viral infection by inhibiting the different steps that the virus uses to cause infection. So for example, over here, you have hydroxychloroquine or chloroquine. It's usually used as an anti-malarial medication. However, in studies on cells, it's known to inhibit the entry of the virus into the human cell. And then over here, you have the remdesivir, which is a broad spectrum antiviral agent. And its main role is that once the virus enters the cell, it'll stop the replication of the virus. So I want to go into details about the studies so far done on these two agents. So the first one will be about hydroxychloroquine. So the most famous study that's been sort of in the newspapers and the media is this study published in the International Journal of Antimicrobial Agents. It's a non-randomized, open-label study that's done from Marseille, France. What they did is they included patients with COVID-19 infection, and they treated them with hydroxychloroquine, and they compared it to people who either refused to be treated with hydroxychloroquine or people from another center that does not have the privilege or access to be treated with hydroxychloroquine. In terms of the outcome, they looked at how the patients can clear their virus by the nose swab repeated at day 6. So these are the study results. I just want to emphasize this is a very small study where you have 20 patients that's treated with hydroxychloroquine and 16 patients in the control group. What I want to emphasize is that the majority of the patients is either asymptomatic or they have mild symptoms. So URTI just means that it's symptoms or infection of the nose and throat and didn't really infect the lungs. As you can see, only about 30% in the hydroxychloroquine group really had a pneumonia. So in these asymptomatic and mild symptom cases, we do not recommend treatment at all. What the study found is that about 70% of the patients who were treated with hydroxychloroquine had cleared their virus based on the repeat nose swab on day 6. And this was found to be significant. So what the authors concluded is that hydroxychloroquine has significantly decreased the viral load and helped clear the virus. However, in my opinion, I think this is a poorly done study and it's flawed in many settings. So the first one is the methodology. So what we usually say is to test a drug, you need the gold standard study design, which is a randomized controlled trial, where you randomize patients to either the drug or a placebo. However, this study did not do that, and the randomized controlled trial is the gold standard because it makes sure that each treatment arm it's balanced in terms of their characteristics. Secondly, in terms of the patients, they had a very small sample size. That means about 30 patients in each group. Truthfully, for studies for testing drugs, we usually need hundreds of patients. And most of these patients have mild disease that doesn't require any treatment anyways in clinical practice. And what I found suspicious was that 6 patients within the study was excluded from the analysis because they got worse in the ICU where they were transferred to the intensive care unit or they died. And those 6 patients, most of them were in the hydroxychloroquine group. In terms of the outcome, I do not think they looked at the right outcome because the outcome we really want to know is the outcome that's clinically important. That means it matters to me, the doctor, and also to you, the patient. That means whether you feel better, whether you get discharged from the hospital, or whether you live or not. And the study did not look at any of those outcomes. Because of these flaws, in fact, what happens is the editor-in-chief of that journal agreed that it did not meet the publishing standards. So this supports that this is a flawed study, and there's not enough evidence right now for hydroxychloroquine. So next, I'll be moving on to remdesivir. So the most recent study on remdesivir, to my knowledge, is the one that was published in 2020 on April the 10th, so just 10 days ago, in the most prestigious journal called the New England Journal of Medicine. What they did is they did a case series study across the world where they included countries including Canada, US, Europe, and Japan. They included all hospitalized patients with severe pneumonia who were able to get the drug, and they treated these patients with the antiviral drug remdesivir for 10 days. And those are given IV, intravenous. Unfortunately, they did not have a comparison group. And for these patients that were treated, they followed these patients for a maximum of 28 days in terms of various clinical outcomes, whether it's how much oxygen they need, whether they clinically improved based on a sliding scale, as marked by the physician, or whether they got discharged from the hospital, or whether they died. So again, this is a very small study where they included only 53 patients that was treated with remdesivir. And again, there's no comparison group. The difference between this study and the last study is that this study had included severe pneumonia for which we needed treatment for. As you can see, the majority of these patients required either invasive ventilation or ECMO, which is just a form of life support. They did found significant improvement, though, in terms of 68% of patients who were treated with remdesivir had a decrease in the need for oxygen. And they found that most of the patients, about 84%, had significant clinical improvement. In fact, that about 57 to 75% of the patients who required life support were able to come off life support. Again, about 47% of the patients were discharged from the hospital, and 13% of patients died. Again, I would say that this is not a very well or of good quality for a study on new medications for COVID. My main critiques are the following. So first, on the methodology, again, this is not a randomized controlled trial, and there's no comparison group. I think this is important because we don't know the outcomes for people who are just treated with supportive care without remdesivir. As far as we know, those patients may have just as good of an outcome compared to patients who are treated with remdesivir plus supportive care. Again, in terms of the patient, it's a very small number of studies, and it's been selected and handpicked by the physicians and the pharmaceutical industries. So that introduces lots of bias, because I think the physicians ourselves will pick patients that we think are most likely to succeed and live. And then thirdly, in terms of the loss of follow-up, for remdesivir, they only follow up for patient about average of about only 2 weeks, and I don't think that's enough, especially for these critically ill patients. It takes a lot of time to just get better. So I just want to highlight that the main reason we're hesitant as doctors to start using them in the hospital setting outside of clinical studies is that these agents, just like any other medications, have lots of side effects. So for example, I just listed a couple, and that's not exhaustive for the side effects for hydroxychloroquine and remdesivir. So the common side effects for hydroxychloroquine or chloroquine is GI upset, so that means nausea, vomiting, abdominal pain, diarrhea. The main thing we're worried about is something called QTc prolongation. It's just hydroxychloroquine has a risk of causing heart rhythm problems, and that could be potentially fatal. For remdesivir, it has major side effects from the studies to cause severe and serious injuries to both the liver or the kidney. Now, of course, these risks and side effects does not happen to every patient, but there's still a significant risk. And our first principle is do no harm at first. So I think I'm just going to end there, but here are my take-home messages. Is one, the clinical diagnosis is based on symptoms, plus usually a nasopharyngeal swab. For the treatment, most cases, and I stress this, most cases are mild, and the infection will resolve by itself, and usually can be managed at home. And for the severe cases that's admitted to the hospital, we mainly do supportive care. Now, there are many potential experiments that's currently undergoing experiments right now, but I think more methodologically sound clinical trials are required before using them in a clinical practice. So I think that's all I had for the presentation.
All right, thank you, Dr. Bai. Bai. Thank you for your time. And I think what you said about the clinical diagnosis, I mean, your entire presentation was very informative. You had clinical diagnosis, you talked about test accuracy, how it's interesting how there are false positives. You talked about the management, where there's a spectrum of diseases. There's mild, severe, and critically ill. You talked about the therapy, where there was hydrochloroquine and remdesivir, and how both of these have side effects to them, so that's why they're not used right now. Right now, unfortunately, I don't think we have time for questions, but at the end, there will be time for questions if you guys have any. I would like to pass the time to my fellow host, Ms. Han now.
Hello, hi. Thank you so much, Eric, and thanks so much for the Counselor Carol and Dr. Bai's sharing. And as you said, that I already seen a lot of the good questions, great questions raised by our audience, but we will leave it to the Q&A session. And next, I would like to welcome Professor Wang to give us some basic common knowledge about the epidemiology concept to help us better understanding the COVID-19